we will hear how the environment and other factors during childhood affects the risk for diabetes in future. And to do so is Dr. Mary Ann Lim, who is the practicing clinician specializing in endocrinology and metabolism at St. Luke's Medical Center and Manila Doctors Hospital in the Philippines. She is also a person who is an avid researcher and teacher, and she has been the president of many associations, including the AFS, that is the Asian Federation of Endocrine Societies. It is my personal pleasure to invite her, as she's also a friend. And with that as introduction, Dr. Mary.
Thank you, Dr. Lech. Before I start, I'd like to thank the organizing committee for the honor and the privilege to speak before you today. My task this morning is to discuss with you whether diabetes risk can be determined before mid-childhood. We will do this by first defining what mid-childhood is, and I will look at critical periods for development of obesity, and discuss later with you a parameter, which is BMI monitoring, to determine what is known as adiposity rebound. So when is mid-childhood? Mid-childhood is the developmental stage between early childhood and adolescence and falls between the ages 6 to 12. It is a time when children move into widening social environments, the school, neighborhood, and peers, where then they strongly influence their behavior. It is a time for significant emotional, social, cognitive, and physical development. The children learn new skills, make independent decisions, and increasingly control their own behavior and emotions. It is also a time for increasing obesity and type 2 diabetes. Let us now go on to look at the different critical periods of development for obesity that then persist into adulthood. Prenatal life has been very well discussed earlier by Dr. Ma, and we will review these 3 stages accordingly. So, shown earlier, the first 9 months are very important. So we will look now at infants of diabetic mothers, the large for gestational age and small for gestational age fetus. Gestational diabetes has been associated with increase in maternal plasma glucose that then crossovers the placenta, leading to increase in fetal plasma glucose, increasing fetal beta cell hyperplasia and hyperfunction, leading to increased fetal insulin and fat accretion. So if you look at the body composition of neonates of gestational diabetics, you can see that their fat mass is increased significantly together with a percent body fat compared to those of normal gestational mother. Largely, this is due to an increase in basal cholesterol, triglyceride concentrations, free fatty acid, glucose concentrations, and a decrease in insulin sensitivity. Let us now move on to look at what the body weight of the mothers are and how it influences neonatal body composition. In looking at the BMI, the ones with BMI greater than 25, although their babies are only about 200 grams bigger, what we see is a significant increase again in fat mass and percent total body fat. So that in a mother who has gained a lot of weight during gestation, they will also have higher birth weights higher weight for their babies or their children when they reach 3 years of age. So the long-term implications of a maternal obesity is providing an abnormal metabolic environment during pregnancy that then predisposes to fetal and neonatal obesity, childhood obesity, and later on, adult type 2 diabetes. So the cycle goes on and on and on. Now let me now focus just for 2 slides on small for gestational age. And this is just showing to you that IUGR, perinatal nutrient restriction, and possibly increased fetal glucocorticoid exposure because of the stressful conditions affect the pancreas, liver, skeletal muscle, and adipose tissue, leading to decrease in pancreatic functional capacity, glucose intolerance, insulin resistance, and type 2 diabetes. In the earlier studies by Barker, he was able to show that small babies have higher risk of mortality, the cardiovascular risk factors to include impaired glucose tolerance and type 2 diabetes. So in summary, for the first portion, what we can say that variations in early life induce altered phenotypes by a process which involves highly specific changes in the epigenetic regulation of individual genes as shown earlier. So now let us now move to the child himself. So we're moving away from the mother and the womb. And at age 1 year of age, let us see what happens. So some babies tend to gain a lot of weight after they're born, and there's a need to clarify risk and benefits of growth during infancy. Clinically, we're often asked by mothers on how big should the baby be. We need to identify modifiable determinants of infant weight gain, and we will look specifically here at infant feeding and sleep. It has been shown that rapid weight gain during early infancy is associated with a higher BMI and more fatness and a central pattern of fat distribution in childhood. So this slide will show us that breastfeeding is beneficial in that breastfed infants gain less weight during the first year of life, as shown in the solid circles, versus the bottle-fed infants, which are shown in the solid square lines. Likewise, the duration of breastfeeding is also important in that the longer you breastfeed the baby, there's lower risk of overweight in these children as they get older. So why is this? Let us now look briefly at human milk. Human milk is a high-fat, low-protein substance, and this contributes to beneficial effects of growth on the growth process. Breastfed infants have slower growth. Studies have shown that the length increase between birth and 2 years is less in breastfed infants, 36.8, versus those that are non-breastfed, 38 centimeters. Rapid growth, either in weight and or length, in infancy or early childhood, can then predispose to later risks because, again, of adaptive mechanisms. So in short, mother's milk is best, the baby knows best. Now, what are the factors associated with increased fatness? I alluded to an imbalance of nutrients when the baby is 1 year old. So what we can see in industrialized countries is that the infant diet is characterized now by a high protein intake, about 4 grams per kilogram